Today we have this patient who is a 60-year-old male, and as you can see from the CT scan here, we are having a mass lesion in the posterior segment of right upper lobe. He is a hepatitis B positive patient, so we are taking utmost precautions. And as you can see from here, there is a bronchus sign which leads into the tumor, so there is a very high possibility we will get a concentric image. And generally the cryo gives a better yield than the forceps, so today we are going to attempt a radial ebus with a cryolung biopsy. This would have been an ideal candidate for a concurrent staging ebus, but since there were some adrenal meds, so the stage is already stage 4. So we will be going ahead with a rigid bronchoscopy and radial ebus and cryobiopsy using a 1.1 millimeter cryoprobe. So let's see how we do it. So right now we are going to do the rigid bronchoscopic intubation. So now you can see that our anesthetist will be carefully holding the neck of the patient, and we are keeping a shoulder roll to make sure that we get the sniffing dog position. So now you can see that we are lifting the patient, we are keeping a shoulder roll, and we make sure that the neck is not too much extended. We are ensuring adequate extension of the neck by keeping some padding below the head ring, and now you can see that we have an optimal positioning of the patient. So now we will go in for a rigid bronchoscopic intubation. We generally choose a 12 or a 14 size rigid barrel. So now you will be seeing the rigid bronchoscopic intubation being done with the modified technique. Now you can see that we are using the modified non-telescopic rigid intubation. I am covering the incisors with the help of a gauze, and I am pushing the base of the tongue outward. And now you can see that I will be appreciating the anatomical landmarks. We are holding the incisors, covering the incisors with the gauze. We are pushing the tongue out. Now you will be able to see the first anatomical landmark, which is the uvula. Now you can see I am putting pressure on my thumb, which acts like a fulcrum, and now I am able to see the epiglottis here. So once you see the epiglottis here, go below the epiglottis, you will be able to see the glottis, and once I see the glottis, I rotate my scope, make sure that I don't injure the vocal cords, and now through corkscrew motion, I am inside the trachea. Now, as you can see from here, I am holding my rigid and securing the rigid in place, and meanwhile we are connecting to the ventilator. After intubating the patient with rigid, now we are passing the thin scope, and we are visualizing the airway. As you can see from here, the airway looks good. There are some thick mucoid secretions in the upper lobe, which we are removing. And now I am going to the left main bronchus, aspirating the secretions there. So once it is done, next important thing is we need to position the Fogarty in place. So what we are using is a Fogarty balloon technique. So you have an accessory channel in the Palstow scope. So we are introducing the Fogarty balloon there. And we want to position it into the right upper lobe bronchus. So you can see after manipulation we have placed the Fogarty blocker in the right upper lobe in the anterior segment. We generally place the blockers in the adjacent segment. And now you can see that we are securing the Fogarty in place. Don't remove my Fogarty now. Now you can see that I am passing the radial probe into the posterior subsegment. Sister, recording ಆಗುತ್ತದೆ. Okay, market ma continue. Wow. Wait. Continue. Not continue. Wait, man. Continue. Mark the tip. Small, very yeah. Continue. Okay. Stop. Your balloon is complete. Fitting. You will take another cup again. Keep another cup ready. Smaller one. Cryo. Okay, now we are taking one donor in the cryo. You can give water. Continue. Keep another ready. Continuous. Now you have seen a case of cryolung biopsy of a lung mass. So the important precautions here are like we need to always try to do it under rigid bronchoscopy, and the Fogarty should be in place for adequate tamponade. This was a high risk case of rigid bronchoscopy and cryobiopsy where the patient was having CKD, he was having a triple vessel disease, and we had to stop the anticoagulation also for 5 days. So when we take such patients for procedures, we always explain them the very high risk concern, and now you will be seeing that the procedure went very well without any intra-procedural complications, and most probably we will be extubating him here and we will be shifting him to the room.